Modern clinical practice is buried in fragmented patient data, a chaotic storm of information physicians must constantly navigate. Right now, the standard approach to integrating artificial intelligence into healthcare treats it as a passive query system. We treat it like a chatbot, an interface designed exclusively to generate a single text response to a direct human prompt. An AI agent functions as a central coordinator, managing the flow of information between models, tools, and memory to execute complex work. Looking at this side-by-side architectural comparison, the left shows the standard linear path. One input yields one text output. On the right, an agent operates as a multi-node circular network, taking independent actions toward a predefined goal. As the linear path fades and the continuous network takes over, the utility and risk profile of clinical AI change completely. To safely deploy AI in clinical settings, medical professionals have to look past the conversational interface and understand this active, hidden architecture. Evaluating these tools is no longer about checking the grammar of a text output. It requires auditing the autonomous systems executing the workflow. We can construct an agent from first principles. This diagram starts with a single, isolated central node, the language model. On its own, this model is isolated. It has no direct access to real-time patient records or specific hospital software. To solve this isolation, we grant the model access to external tools, like clinical databases and specialized software. The control mechanism linking the model to these tools is the agentic loop. It begins with the perceive phase, where the system analyzes the assigned task. Next is the plan phase. Here, the central model maps out the logical sequence of steps required to accomplish that task. Then it acts. The system reaches out to query the external clinical databases or software tools to execute its plan. Finally, in the observe phase, the model evaluates the results of that action and updates its internal state. This exact sequence repeats continuously. The agent loops through these phases over and over to break down and execute complex, multi-step tasks independently. This perceive, plan, act, observe cycle is the specific engine that turns a static language model into an active clinical agent. In a real hospital environment, clinical work operates through strict, multi-step workflows, rather than simple one-off questions and answers. The first standard step of a clinical workflow is the routine gathering of fragmented patient history and lab data. The second step is the synthesis and structural interpretation of that collected information. The final step involves drafting formalized clinical documentation based on those interpreted results. This linear flowchart shows those three standard phases: data gathering, interpretation, and documentation. The agent's looping architecture maps perfectly onto this sequence, continuously cycling to execute each step in order. Agents are built to handle these highly structured, routine data tasks that heavily tax physician time. The clinical objective of the agent is the reduction of structured cognitive load, leaving the actual clinical judgment entirely in human hands. Traditional evaluation fails here. Because agents execute end-to-end processes, scoring the accuracy of a single isolated text output reveals very little about the system's actual performance. This evaluation matrix highlights the required shift. While the top method stops at a basic accuracy checkmark for a single text block, the bottom method tracks success across multiple discrete workflow nodes, measuring end-to-end task performance. Measuring a full workflow requires specific metrics, beginning with the agent's absolute task success rate across the entire process. It also requires auditing tool appropriateness to verify whether the agent queried the correct database and used the correct search parameters during the act phase. Evaluators must identify specific failure modes and measure the system's consistency when dealing with drastically different patient cases and varying hospital settings. Agents operate dynamically within real-world workflows. Therefore, their evaluation parameters must be workflow-centric, with clear definitions of success, failure, and acceptable risk. The sequential loop gives the agent its capability, but it also creates its most critical vulnerability. The primary points of failure occur when the agent relies on poor data quality during a tool query or generates an internal hallucination during the planning phase. Looking back at the circular loop, an isolated error can occur precisely at the act stage. This happens when the system retrieves incorrect information from an external tool. This triggers error propagation. The incorrect data is carried forward into the observe phase, where the agent logs it as a factual observation. The agent then uses that corrupted observation to inform its next step in the plan phase, permanently baking the mistake into its future logic. Because the system lacks intrinsic medical intuition, it will proceed confidently, generating a final document built entirely on compounded errors. In an agentic system, mistakes are not isolated. A single micro-failure early in the loop will invisibly multiply into a macro system failure by the end of the workflow. The clinical AI agent is an autonomous workflow engine, driven by its access to external tools and internal memory. Its success depends on the precise management of its planning and feedback loops, not merely the size or parameter count of its underlying language model. Because these AI systems appear highly capable, they introduce a severe behavioral risk for medical professionals: human over-reliance. This outlines the definitive deployment rule. The system's generated output must halt at an impenetrable gate. The agent acts strictly as an assistive system. Active clinician oversight must serve as the final barrier before any clinical action is taken. AI agents will streamline the administrative burden of healthcare, but the ultimate responsibility for clinical truth remains permanently with the physician.